Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who attended with a really blocked left ear, and this is actually an examination of their better right ear. You can see that ear was pretty clean. There's a bit of non-occluding wax, very laterally near the entrance at the base, the floor of the ear canal, which didn't really want removal. But this is the ear in question, and they had used a cotton bud. You may have seen the indentation. You can see the imprint of the cotton bud, and which has really impacted and embedded this wax into the patient's ear canal. Now, the wax is quite sticky, which can make it a bit more difficult to suction, because when it's sticky like this and glutinous, it tends to reduce the suction flow, and it can block the inside of the sucker. Therefore, I've instilled some olive oil medical grade ear spray. The particular brand that I use is called Clear. I am also their healthcare advisor, so I'm just doing my normal pitch of the product. Now, if you are a specialist and you wish to purchase the Clear olive oil medical grade ear spray, so you can use in your procedures and also sell on to your patients, visit our website, www.clearwax.co.uk. Select sign in and then register an account. Please do ensure when you register an account, you select you're registering it as a professional, and that'll give you access to our trade shop with trade prices. And if you are a member of the public and you wish to purchase it, please visit our website. You'll see our public online shop and you can purchase the Clear olive oil ear spray. And what the olive oil ear spray does, you may have seen it here, it's really changed the consistency of this wax. It's binded it together. Now, I enjoy my food analogies, being a foodie, and I always compare it to an egg. I know some of you must be sick of me making this analogy, but if anyone new to my channel who have not heard it, I always compare olive oil ear spray like an egg in a potato or fish cake recipe. It helps to bind all the ingredients together, and similarly the olive oil helps to bind this wax together, so it's easier to suction. It still can block the suction probe. You saw there, I gave it a little wriggle to help the wax travel through. Now, you'll notice once I remove this wax that they have got quite a prominent posterior ear canal wall. So it's like a bulge there. And it's not visible to the naked eye at the moment, of course, because of all the wax. But so when we say posterior, we mean the back part. So to the right-hand side of the ear canal, it does protrude out a bit more than the norm. Now you can see the eardrum already, so the patient's hearing loss symptoms have been completely eradicated and alleviated. They can hear as they once did prior to having this wax build up. But whilst the patient's here, I'm just going to try and mop up some of this wax that's lining the canal wall. You can see here at the base, it's somewhat solidified. So I'm just rocking. You may see that rocking motion of the sucker just going backwards and forwards. Now, because of the consistency, some of it is stuck to the canal wall, so we're not going to get every little speck out. The only way you would do that is by scraping the patient's ear canal to remove this wax, and that would be really uncomfortable. We don't want that for the patient. And so this wax, it's like a thin lacquer. It's like a veneer just over the canal wall. So we just got to hover over, and you got to have a good guesstimation, should I say, for the thickness of this layer of wax. If it's a really, really thin layer and you expect it to be a thicker layer, you're going to go in a bit more with the sucker against the canal wall, and you will make contact with the ear canal, which will be really uncomfortable. So when we make contact with the inner 2/3 of the ear canal, it can be incredibly uncomfortable for the patient, and that's because we're touching exposed bone. The inner 2/3 of the ear canal, the bony part, it's only protected by the thinnest layer of skin, which is less than 0.1 millimeters in thickness, so it's very exposed, and if you touch exposed bone, it can be extremely uncomfortable. The outer third of the ear canal differs because that's made up of cartilage, and that's protected by a thicker layer of skin, about 1 millimeter in thickness, or 10 times thicker. And cartilage is malleable, it's flexible, and there's also some fatty tissue, some muscle there as well, that's just protecting the cartilage. So we've got to be careful. So we're on the cartilaginous portion here, so now I can put a bit of pressure, but as soon as I'm about a centimetre into the ear, I've got to be really, really gentle. So I've just reverted to the fine end sucker. So the fine end sucker, it just gives us a bit more fine motor control. We can perform more precision procedures like this with the fine end sucker. And if we do make contact with the ear canal wall, and we do, no matter how steady a hand you've got, the ear is really, really small, and it's inevitable that we all make little contacts with the canal wall. With the fine end, it's less traumatic, so it's less invasive, it's less uncomfortable for the patient if you make contact. It's also a lot quieter because we've cleared the blockage already. The suction, microsuction can be quite noisy. I was pleasantly surprised when I had it performed in my ear. Now, so whenever, so I don't really have any wax problems, but during our training courses, we would often demonstrate in my ear. So my colleague, Mr Rajali, is an ENT surgeon who would inject artificial earwax into the ear. I won't give away the recipe for that. And he will then simulate a procedure on me using the artificial Vaseline, which is what I still use when we train our specialists. We all train on each other's ears, and if a specialist doesn't have wax, we can inject some artificial earwax, of course with their consent. And when Mr Rajali performed microsuction in my ear, I was pleasantly surprised. I just had a tendency of closing my eyes. It wasn't uncomfortable, and the noise was tolerable, but it kind of made my eyes water a bit, and I was squinting. And Mr. Rajali he asked me if I was okay, and I said yes. I was totally fine, but it was just my bodily reaction, a reflex, where I had to close my eyes and squint. So of course, Mr. Rajali thought that it was uncomfortable for me. It wasn't. It was just a reaction. It's like when I go to the barbers, I always close my eyes. I don't know why. We've all got these idiosyncrasies, should I say. And you can see that skin there. I've just peeled that away, and the posterior part of the ear canal is bulging a bit. So yeah, a fine end, going back to that topic of conversation, the fine end sucker, it's less noisy, which is always helpful when the ear is already clear. And this ear canal, you can see, like, we go up, and you can see, like, the top of the canal wall, and then it dips back down. So I suspect with this particular patient, it's going to be a chronic issue because of the ear anatomy. The earwax has to go up a mountain and come back down again. So it has to go up a hill, an elevation, for it to naturally migrate. And I suspect it's going to find it difficult to do because of the ear anatomy. So I'm just mopping up just around the edge. We're just going to, I think, clean the lens in a moment, or am I going to go straight back in? We're going to go straight back in. So there's a few flakes of dry skin there. We're going to leave that because it can clarinet and it's not significant. Patient's really, really happy. They could hear. I hope you enjoyed that video, guys, and you're all taking care and looking after yourselves. Speak soon. Bye.